So in this question, they're asking, which of the following most likely to both decrease the renal plasma flow? So you have to bring in less blood, but an increased filtration fraction. In another word, increase in GFR. Does that make sense, folks? This question is asking increase in GFR, decrease in renal plasma flow. To do both opposite, it has to be constriction of the efferent arteriole. When you constrict the efferent arteriole, you increase the GFR and then you decrease the renal plasma flow. If you do D, both are going down. Does that make sense, folks? They both are going down. So you have to be careful. Okay. So that's that. Okay. So this question is the same as the previous one, but they're asking on the other way, right? They're asking with the constriction of the efferent arteriole, which of the following changes to GFR, right? What happened to GFR when you constrict the efferent arteriole? Pressure buildup, traffic jam increases. GFR increases, isn't it, folks? When you constrict EFF, traffic jam. So all these are gone. Is that clear, folks? Whenever you constrict EFR, the EFF, GFR increases. When the GFR increases, renal plasma flow decreases. But here they didn't show renal plasma flow. So the only option is to go with the filtration fraction. They both goes in the same direction. Literally, this question is this. They're asking other way around, folks. Okay. They're asking the other way around. So that's the answer. Okay. So what's the main problem here? 48-year-old woman is evaluated for postcoital bleeding and vaginal discharge. Pelvic exam shows friable mass at the cervix that bleed easily. Cervical biopsy confirm invasive squamous cell carcinoma. Okay. Lymph node is not seen. A radical hysterectomy is performed during which the right ureter is accidentally injured. Imaging studies performed after the surgery shows partial obstruction of the right ureter. Okay, so there's a basically this is an obstruction of the ureter. It's like constriction of the ureter. In your book, you have constriction of the right. So what is happening here? Which of the following changes are most likely seen? Look at that's your fourth option in your book, folks, not fourth, fifth one. Constriction of the ureter. If the ureter is constricted, urine back up and that urine pressure increase, so the GFR has to be decreased. Is everybody clear, folks? If the GFR decrease, filtration fraction also decrease. That's the only option. Okay, so you have to be very careful with this. Look at this. It's a beautiful picture. When the urine backs up, Their pressure is high, so nothing can come down. Is that clear, folks? So that's the idea here. Now I could even add one more column here. RPF, what happened to RPF? No changes, because the blood flow will keep flowing it. Is that clear, folks? No changes it. See, these 3 questions we did, it's literally from this chart. All those 3 questions from this chart. Is that clear, folks? All right. So make sure when you review this question this afternoon, you understand that that's important, folks. All right, let's go here. Now, again, you do not have to memorize any of those. You just have to learn some here. How do you calculate, folks? Okay. For example, if we want to know how much we reabsorbed, all you have to know how much we filtered, subtract from how much we excreted. So then we know how much is the reabsorption. Is that clear, folks? So that's the idea here, folks. If you want to know how much you secrete, take the whole amount of you excrete and subtract the filter. The difference is how much you secrete. It's just a way to see. I don't see a point of knowing this, but at least you could get the amount if you need it. The only terminology that I want you guys to remember, this will come to that later. Fractional excretion of sodium. That means how much sodium you excrete in the urine per fraction. Fe sodium goes in the same direction with urine sodium. There's 2 things we'll talk about it. Same direction. Just write this, I'll come to that. One is per fraction, the other one is total. That's a different, folks, okay? One is per fraction, the other one is total. Just remember that now. Now, next one. This is important. Now, to learn the basics, folks, we filter 100% glucose. We filter 100% glucose, which means every single glucose comes into this. Do we see glucose in the urine? Is it normal to see glucose in the urine? No. So all the 100% is reabsorbed. Is that clear, folks? So always remember, even though I say the word glucose, including amino acids, okay? Glucose and amino acid, they both are 100% filtered. After that, they are reabsorbed 100% in PCT. That's very important. Same thing here, folks. Now, there are some diseases here. Glucose at a normal plasma level, range 60 to 120, is completely reabsorbed in the PCT with the transport. That's fine. So that's why they say at fasting, if I fast for 8 hours and I check the blood glucose, it should be less than 126. Is everybody clear, folks? That's a normal blood glucose level, okay, less than 126. As long as you maintain less than 126, you're not going to have any problem with the glucose in the kidney. Everything will be reabsorbed. In adults, at plasma glucose of 200, glucosuria begins. So when our blood glucose becomes 200, that's high. Then we started excreting a little bit of glucose, right? That glucosuria begins. At the rate of 375, all the transporters are fully saturated. What does that mean? In here, there's a transporters to reabsorb, right? If you have, for example, 10 transporters, they could only bind to 10 molecules of glucose. Does that make sense, folks? Once all the 10 is bound, they are fully occupied. There is no more to reabsorb. So if any other glucose comes, they will go straight in the urine. Is everybody clear, folks? So that's what it tells you, that it's a reabsorbed, folks, okay? Now, before we read anything else, look at here, folks. At 200, they start glucosuria. By 375, is fully saturated. That means it comes to a flat rate. Between 200 to 375, that timing is called splay. If I tell you the patient is in splay, you should know the blood glucosuria begins, but has not gone through the saturation yet. Is that clear, folks? So they are in the middle between 200 and 375, folks. Okay, that's what the splay means. It's just for research purpose. You need to know. In the clinical, you would never use it, folks. So that's the idea. Okay, between 200 and 375 is what we call splay. Is everybody clear? All right. Now let's see. See, for me, this is important. You should know this well. Normal pregnancy is associated with increased GFR, with increased filtration of all the substances. What does that mean? It's very normal to see a little bit of glucose in a pregnant ladies. Okay, because why it's normal to see urine glucose in pregnant people? Because their threshold is very low. Look at this, glucose threshold occurs at a lower plasma glucose concentration. So normally, when do you start excreting? At 200, isn't it, folks? When a person is pregnant, probably it will start excreting even at 150. So that's a low threshold. That's what the problem is. Okay, but once the baby comes out, everything will go back. Or some people continue diabetes, right? That's why when they are pregnant, we are very picky on their blood glucose level for gestational diabetes. Because why? Gestational diabetes will put the baby at risk for developing what disease? Neonatal respiratory distress syndrome, isn't it, folks? Because insulin inhibits surfactant. Okay, so that's important, folks. Okay, so that's that. Next, we talked about this in diabetic medication. You see this transporter, sodium glucose co-transporters here. There's a co-transporters that reabsorb sodium. You could technically block that. If you inhibit that co-transporters, all the glucose will be excreted. That's what they're telling here. So we use that if they're in an extreme diabetic condition, if none of the medication is working, we use this medication. We also studied endocrine. We do not use that much. Why? Because when the glucose comes in the urine, you are attracting all the fungus and bacteria. Does that make sense, folks? So that's why we don't use this unless it's really needed. Glucosuria has never been a normal, folks. It's a clue for diabetes. Is everybody clear here? Okay, so that's, we shouldn't even see mild glucose. That's a bad sign. That's the idea, folks. Okay. Now, this only applicable to adults, not for kids, because kids eat more sugar than adults. So it doesn't work like that, folks. Okay. So that's one physiology. Now let's go here. This is the last part of physiology for kidney, folks. But this page is the most important. You know, we studied everything to understand this page. If you know this page, you know the pharmacology, because all the kidney pharmacology works on this chart. Okay, all of them works on this chart. We're going to have to go through step by step. Now, before we do it, we kind of need to orient ourselves, right? Now, let's take a look here. Now, let's say I'm continuing to draw this. If I were to draw, your PCT will have like this, okay? Now imagine, folks, if I cut a section of this, and I should also have peritubular capillaries here, isn't it, folks? So if I cut and take this, what should I see? This is where the urine site, this is where the blood site. Is that clear, folks? Same thing in this book, if you see. This is where the urine is, this site, and this is where the blood is. Is everybody clear, folks? So this is a separate, okay, 2 pages. They are putting it in one. So this is where your peritubular capillaries are, peritubular capillaries. So another terminology, they actually asked a question on NBME, one simple question, it blew everybody. The blood, whatever the side the cell is facing blood is called basolateral membrane. Whatever the site you're facing urine is apical membrane. They simply ask a hormone, where does it exactly work? Does it work on the basolateral space or it works on the apical membrane, right? Now that's something, so for that you need to know the place. So that's what it is. Okay, is everybody clear so far? Okay, so first we're going to start early PCT. That's your proximal convoluted tibial. And this gets complicated, folks, so good focus is important, okay? You could read everything later onwards, but go with me what I'm covering here. The early PCT has a brush border. Why do you need brush border? To increase the surface area so you can absorb better. We reabsorb glucose, amino acids, most of the bicarbonate, and sodium. That's the idea, folks. And then water, of course. See, whatever I highlighted, that's the most important, and uric acid finally. Okay, you cannot forget glucose, amino acids, bicarbonate, and sodium. Okay, so these are all reabsorbed. What does that mean? Going from urine back to the blood. Is everybody clear, folks? All of them are going. Okay, now you could see sodium is going this way, and some of them they are not shown here, but all of them goes here, folks. Okay, glucose is going this way. I don't see amino acids, but it should be. Okay, now the drawings are not always best, but this is high end. Is everybody clear, folks? So they're reabsorbed. Okay, now the only thing that they excrete is phosphate. Your kidney excrete phosphate, folks. Okay, it's important. With the help of PTH, they excrete phosphate. So what do you need to know clinically? Whenever a patient comes with kidney failure, in the blood, their phosphate will accumulate because you cannot excrete anymore. So one of the findings of kidney failure is increased phosphate. Is everybody clear, folks? All right. Next, angiotensin 2 works here, and they increase sodium and water and bicarbonate reabsorption, folks. You should know most of the bicarbonate are reabsorbed in here, folks. Now it says 65 to 80% of the sodium and water is reabsorbed in early PCT. Okay, now I'll come to this line a little later once we are done. So if I say early PCT, what are you going to tell me? We reabsorb amino acids, glucose, bicarbonate, and sodium and water, and we excrete phosphate. Is everybody clear, folks? If you know that much, you would not miss a single thing on early PCT, folks. Okay, so that's all you need to know. Now, next, thin descending loop of Henle. They didn't have a picture here. There's no picture for that, okay? Now, the thin, why do we call it thin? Now, you could see here, this is PCT, and you could see thin descending, okay? That's your thin descending, folks. When it comes to thin descending, they passively reabsorb water. They only reabsorb water. They are not reabsorbing anything. You see, impermeable to sodium. I guess we need to draw that diagram, otherwise it's hard. Let's say. So let's assume this is your. This is how the segment goes up, folks, okay? Of course, I didn't do the thin descending, so it should be from here to here. So, okay, so that's your thin. So you want me to do the thin, I'll do it. Okay, so these are called thin descending. In thin descending, what's happening here? Only the water is absorbed, okay? Only water. So if you absorb water, what are you leaving inside? Sodium inside, isn't it, folks? You are taking the water, leaving the sodium. Sodium is what gives you the concentration of your urine. Does that make sense, folks? So what happens if you take the water and leave the sodium? Your urine will become very concentrated. So that's why in the book it says, thin descending loop is a concentrating urine. They could ask you what happened to the urine. Urine will be very concentrated at that point, folks, okay? It makes urine hypertonic, concentrated. Okay, remember, even though you have a sodium, adding water dilutes, taking out the water, concentrate. Is everybody clear, folks? All right, so that's thin descending loop of Henle. Any questions so far? So the only one thing that can come out of the tubules in thin descending is water, nothing else. Okay. Now we are moving to thick ascending loop of Henle. So when I say thick ascending loop, that's here, folks. Okay. Thick ascending. Thick ascending. Thick ascending, folks. So that's thick ascending. Okay. Now let's take a look here. There's a beautiful picture here. Now work with me here. In thick ascending, we reabsorb 1 sodium, 1 potassium, 2 chloride. All these things are reabsorbed. Forget about the medication here. Sodium, potassium, and 2 chloride is reabsorbed in this section. When they do that, follow me here. Potassium is coming in, so inside the potassium is high. Agree, folks? That increase in potassium again leak back. We call this back leak, okay, which means they're leaking back into the lumen again. And by leaking, you are creating a positive potential. This is super high yield. That leaking back is called positive potential. That means you have more positive ions, right? Because we know potassium is a positively charged. That positive ion helps magnesium and calcium to reabsorb. So in order to reabsorb calcium and magnesium, you need that potential. Okay, so 2 things we need to learn here. Let's go backward now. In order to reabsorb magnesium and calcium, I need back leak of positive potential. How does it happen? It's you reabsorb and then you leak back. That's a whole process. Is everybody clear, folks? Now, what else did you notice in this picture? We reabsorb magnesium and calcium paracellularly. What does paracellular mean? Between 2 cells, not within the cells, not through the cells. You see, they didn't go inside the cell. They're going in between 2 cells. Is everybody clear, folks? Now, if you read this, it says reabsorb sodium, potassium, and chloride indirectly induces paracellular absorption of magnesium and calcium through positive lumen potential generated by back leak potassium. So that back leak of potassium is so important to reabsorb calcium. Is everybody clear, folks? All right. The urine becomes less concentrated acid as such, so we'll see that. Now let's talk about the clinical here in this section. Let's say I have a patient who had a history of kidney stone, or they just had a kidney stone recently. Okay, they just had a kidney stone recently. Would you give loop diuretics? Let's see how does loop diuretic works. So loop diuretics inhibits this. If you inhibit, there is no increase in intracellular, so there is no back leak. If there is no back leak, there is no reabsorption. All the calcium is going in the urine. Is that clear, folks? So that means, would you, now you tell me, would you give loop diuretics to somebody who had a kidney stone? Abby, would you still give it? You wouldn't, okay. Loop diuretics are contraindicated on people who had a history of kidney stones. Why? Because giving loop makes more calcium in the urine, which means they can precipitate and grow stones. Is everybody clear, folks? So you never think about loop for somebody who had a kidney stone before. Again, when I'm talking about kidney stone, I'm talking about calcium stone, not other stones. Okay, that's the idea. So everybody clear, folks? So maybe you want to write it down somewhere here. It's contraindicated with the history of kidney stone. Contraindicated with the kidney of stone history, folks. Who should you give it to? Tell me a medical condition that you will give loop diuretics.
Thiazide diuretics.
No. Who would you give loop diuretics?
Hypocalcemia.
If you give hypocalcemia, you will make it worse, isn't it? So
Oh, no. Hyper.
Hyper. There you go. So the patient you want to give this who has hypercalcemia, that means they already have more calcium in the blood. I don't want to reabsorb any more. So you could give loop that can help to excrete the calcium in the urine. So you will not reabsorb. Does that make sense, folks? So you don't give it to people with kidney stone, you give it to people with more calcium in the blood, hypercalcemia. Is that clear, folks? All right. Make sure you take those notes. Okay, so giving loops makes more calcium in lumen. Is everybody clear here, folks? Okay, so now we are here. One of the things that, okay, let's continue this diagram also. So this diagram will come like this, folks, eventually, okay? So let's say it comes like this. So we call this DCT, and this is collecting duct, okay? We'll see a nice diagram on the UWorld. After we finish this, we have literally about 10 questions just in this page. Okay, 10 questions, we're gonna do this. That's the only way to learn that. Now, so far, if I ask you, I'm gonna name this A, B, C, D, E, F. I didn't talk about F, so ignore F. No, I didn't talk about E either. Which segment so far that you learned that will have the highest concentrated urine? Type it out. Which segment would you have the highest concentrated urine? Everybody's going to B because that's what Dr. Roy said. Which is true, but the actual answer is C. Why is that, folks? Even though we are reabsorbing all the water here, the urine is concentrated. But keep in mind, the gravity will take it down. Is that clear, folks? The gravity will take it here because they cannot go against to it. So segment C, what do we call? That is the junction between thin descending and thick ascending. That is where the most concentrated urine without the involvement of collecting duct. Okay, we are not going to bring collecting duct at this point. Okay, that's the most concentrated. So it will make sense, folks, when I'm done with the collecting duct, it will nicely come to you guys. But at this point, I just want you to remember. Okay, now when you say urine is concentrated, right? Urine concentrated. Don't just blindly memorize that. Ask yourself, in which situation, there's two situations your urine can be concentrated: while you are dehydrated or while you are normal. Is everybody clear, folks? So the C is the answer when you are normal, not dehydration. Because why? If you have dehydration, ADH is going to come to play a role, isn't it, folks? That's different. Okay? I'm just going to tell you this quickly. The C is the most concentrated urine in a normal people. F will be the concentrated urine in people who's dehydrated. Is that clear, folks? Because your ADH works here. Okay, I'm going to get into that, but I just wanted to give you these pictures. So whenever you read a question, they ask you, which segment is most concentrated? Ask yourself, is this person is normal, or they are giving any hint that person has been dehydrated for whatever reason? Is that clear, folks? Whatever reason. Okay.
That example on your road, there was a question I always got wrong. A patient, someone was stuck in a desert or something, and I always picked C.
It's wrong.
Case. Yeah.
Okay, so we'll come to that. C is the wrong answer if the person is from desert, because that means they're dehydrated. So it has to be one of the choices in F. Is that clear, folks? So you could only pick C if they are healthy. Is everybody clear, folks? That means there shouldn't be any sign of dehydration. It will make a perfect sense once I finish this whole page. But are we clear so far? Okay, so again, what's the name of this C? It's a junction between thin descending and thick ascending. Okay, that's a junction, because sometimes they don't explain, they ask you actually with the word. Okay, that's the junction, folks. All right. So once we are done with thick ascending, which means now we are going to this area. Okay, this is your DCT. That's your DCT. Now, if you see here, folks, DCT, again, it has its own urine and then blood on this side, so the basolateral and then the apical membrane. One thing you want to learn, DCT is we reabsorb sodium. Forget about the thiazide, we are not talking about that now. Reabsorb sodium. They also reabsorb calcium, because we learn in DCT, your PTH works, isn't it, folks? Do you remember how does PTH works? Let's recall that. PTH works in the bone, and it also works on the kidney. We remember this chart we draw. In the kidney, it works on the two places. One is PCT, other one is DCT. This is a drawing I did, isn't it, folks? What does it do in PCT? Activate alpha-1 hydroxylase. It activates alpha-1 hydroxylase, so you can convert the vitamin D to active form, and then that does. But in DCT, I remember explaining it directly reabsorbs calcium. Is everybody clear, folks? That's exactly what it is. Look at that. PTH binds and reabsorbs. Are we clear, folks? So if I ask you what happens in DCT, you just go say sodium and calcium reabsorption. Are we clear, folks? Okay. Now, if I ask you where exactly PTH binds, does it bind in the apical membrane or basolateral membrane? Answer is basolateral membrane, because that's where they bind. Is that clear, folks? Literally, it was a similar question on the NBME. Instead of PTH, they ask ADH. Where does ADH work? All the hormone works on the basolateral membrane because they have to come through the blood. Does that make sense, folks? No, the student who missed in the question I asked, how did you miss this question? I didn't know. Logic. Can you have a hormone come in the urine? No. So it has to be the other side. But where the student went wrong, they didn't give the picture. They used the word apical, basolateral. The student didn't know where the apical, where the basolateral is. You see, one simple mistake, you lose that question. Careful. So that's your DCT. Now you could see it reabsorbs. Impermeable to water. Highlight that. Impermeable to water. What does that mean? That means in this section, all the water is staying inside the urine. What is the tubule? All the urine is the water is staying inside the tubule. What does that mean? E is the answer. If I ask you, where do you have the most diluted urine? Is that clear? DCT is where you have the most diluted urine. Most diluted. Okay, it's important. So usually what they say, as you go up ascending, you will become more dilated, because demographic ascending also a little dilated, but this is the most dilated. You see here, it makes urine fully diluted. So it's a clear folks. And sodium, they're talking about calcium absorption and these things. Now, when you give thiazide, one thing that you should learn at this point, thiazide increases the reabsorption of calcium. Thiazide, this is opposite to loop diuretics. Loop diuretics stop the reabsorption of calcium. Thiazide actually increases more reabsorption of calcium. So, which means when patient comes on the kidney stone, we should give thiazide. Is that clear for you? Because they reabsorb more, that means calcium is going to the blood, less calcium in the urine, so they won't want to stone. So everybody clear, folks? So I will write right here. When it comes to kidney stone, the question is, who increases urine calcium? Who increases urine calcium? Okay, that's what it is. Right? Urine calcium. Who increase the urine calcium? Increase urine calcium is loop diuretics, decreases by thiazide. Everybody clear, folks? Okay. Put that in the brain. That's a very important concept. You cannot forget that.
I have one question. The calcium that we get out of in the DCC is the one that came out in the
loop. Yeah. Okay. So that's the idea. So whatever you miss here, it will come back. You see, you have 9 months to play around with that. Okay. Always remember. That means urine calcium increased by loop characteristics, decreased by thiazide. So people with kidneys on, this is the indicated. This is the one that can attach. Is that clear, folks? All right. That's a very, very important concept because kidneys don't are a very common problem. Okay. So that take care of your DCC, folks. Is everything clear? Okay. Now we are at collecting duct. Now, before we go collecting duct, I want to go back to endocrine recall. What does aldosterone do? Aldosterone reabsorb sodium and water and secrete potassium and hydrogen. You guys remember this? You guys are learning this. Right. So we reabsorb sodium and water. That's how we increase the blood pressure back up, isn't it, folks? And we exchange sodium and potassium and hydrogen. That's where does it work? Collecting that. So clear, folks. Before you get the collecting that, we should recall all the theories first. Second, ADH. What does ADH do? Reabsorb water. Only isn't it, folks? They reabsorb water. Okay. And we know the water goes from urine back to blood. So the urine becomes more concentrated. Is that clear, folks? But then we also learn, do everybody say ADH all the time? So no, you only raise ADH when you are dehydrated. Is that clear, folks? If you are not dehydrated, you will never release ADH. Okay. All right. Now let's go back. Let's start with ADH first. Look at this. This was that ADH question I was talking about, folks. They literally asked where does ADH work? ADH goes by binding ADH receptor on the basolateral membrane. And then they said something called aquaporins. Aqua means water. Porins means small pores. They put that in the air on the apical so the water can reabsorb. So I could be very technical here. I could say ADH works on the basolateral. They bind to basolateral and reabsorb the water actually in the apical. Is that clear, folks? So you have to be careful whether they ask in ADH or aquaporin. If I ask you where does aquaporin work, that's apical surface. So everybody clear, folks? That's your ADH. Now always remember, ADH only comes when you are dehydrated. So when you are dehydrated, what's happening in this segment? All the water is going inside. So this is very concentrated urine, folks. That makes sense, folks? So the answer is here. C and FR, both are concentrated urine. One is under normal condition, the other one is under dehydrated condition. So very clear, folks? All right. Let's continue here. So ADH, is everybody clear with ADH? Now look at aldosterone. Now before that, collecting tubule also has two cells. One we call principal cells, then we call alpha and beta intercalated cell. Just know that there are two different types of cells. That's all you need to know. In collecting tubule, there's two different types of cells. Principal, these are histology. Now if you notice it, ADH only work on principal cells. So that's something I will pay attention to. They could check that. ADH doesn't work anywhere else, only in principal cells of the collecting duct. Okay. Only principal cells of the collecting duct. Now, if you take aldosterone, it's different. They work on both principal and intercalated, right? So here, you don't have to worry. They're excreting potassium, excreting hydrogen, and they're also reabsorbing sodium. We know the function, folks. When you know the function, it makes it easier. Okay. All I want you to take notes, home notes. Aldosterone reabsorb sodium and both excrete hydrogen and potassium. They work on both cells. So everybody clear, folks? If you know that, you are good. Okay. Now, whatever I explained, it's written here. And the same thing. You see, they started adding H2O channels on apical side. That's the idea, folks. So everybody clear so far? So we just did the basics. Now there is about 4 concepts that we need to learn. The only way I can make this easy by doing those questions. So by question, we're going to break down and learn it, okay? So review what we have done while I pull out all those questions, folks.
I also had another question for DCT. You know how you said in the beginning that it sits on top of the efferent field? So,
AFF,
infant,
AFF, okay?
infant, right? So on this, when we are taking the sodium and then we're using the ATP pump to pull it out, right? So that's where it's going back into the efferent.
It doesn't go to AFF, they just scan. They are just sitting next to AFF and they just scan it. It doesn't go back to AFF. When we reabsorb, it goes back to peritubular capillaries.
Okay.
Okay. So it does not go to AFF. There is no connection. It's just sitting and watching, but they cannot put it back. Why do they have to put it back in AFF? They are just seeing how much it's coming in AFF.
So you said something about how just like glomerular cell and sodium goes back.
So let's go back here. Let me. So here. See, when you see this diagram, the DCT is right here. They are scanning how much sodium is coming in AFF. So by the time this sodium goes here and come here, they could reabsorb from here and put it on the peritubular capillaries. Okay? All right. Give me 1 sec. All right. Now, there's some warnings. When you do this 8 questions, probably you will feel the most frustration today with the UWorld. Okay. But don't think it in this way. You're going to learn it. But I promise after we finish 8 questions, you will become pro in this 4 concept. Go ahead. Okay, so we're going to learn it together. A nephrologist at a research hospital are investigating a physiological change that occurs in diabetes insipidus. That's fine. The group developed a technique that permits sampling of tubular urine in experimental animal that's similar to human. We could ignore all those 3 lines here. They're saying they're doing a research that's similar to human. The animal then undergo hypophysectomy. What does that mean? Removing the pituitary gland. Is that clear, folks? They remove the pituitary gland. Why do they have to say that? They are saying here that means there is no ADH. Is everybody clear, folks? Okay. After which tubular fluid samples are obtained from multiple sites throughout the nephron. In the absence of ADH, which part of the kidney will have the highest osmolarity, right? Now, forget about the ADH. If I show you in this picture, let's go back. Which are the 2 parts that has the highest osmolarity? It's going to be C and F, isn't it? C and F should be the answer. Oh, my letters are matching with my drawing. Okay, that's C and F. F is influenced by ADH. C is non-influenced. Does that make sense, folks? That means in this particular question, they said absence of ADH. That means it's not F. That means it's in C. Is everybody clear, folks? Now, another way of asking the same question, the patient is not dehydrated, healthy people, because ADH will only come if you are dehydrated. Is everybody clear, folks? All right, so that's C, okay? So let's see. Okay, C, I get palpitation, all right. So to make sure, because it's a very dry topic. Now, so the concept here, very important. The C and F both are concentrated, but C is concentrated in a healthy people, and F become the answer when they are dehydrated, because when they're dehydrated, ADH comes to play a role. So everybody clear, folks? Okay, so that's one concept. All right. So little break to your brain, easy question. In this question, they're asking, where do you produce erythropoietin? Make it easier. Isn't it? Erythropoietin is important for red blood cell, right? I asked this question at least 3 times, right? Where do we produce? I thought this will make it a little break for your brain. I didn't know this is also becoming harder. All right, just help you with. Don't pick C, that's renin. Okay, C is renin. Peritubular capillaries is where you produce erythropoietin, folks. Okay, always remember peritubular capillaries of the kidney produces erythropoietin. Make sense? When you release erythropoietin in peritubular capillaries, it's going to come to renal vein to inferior vena cava. It can go to the whole bone marrow. Is that clear, folks? All right. So that's the idea here. When people have a renal failure, when we studied in hematology, we said normocytic, or even we said non-hemolytic anemia, right? When you have a chronic kidney disease, people don't have erythropoietin. Is everybody clear, folks? All right. That's what the answer for this. All right. Give me 2 answers for this option. I like 2 options. Okay, so this question is asking, 34-year-old woman comes to the physician complaining of frequent urination. She has tried limiting her fluid intake, but found it difficult because she got very thirsty. The physician assessed the water conserving function of her kidney by performing water restriction test and shows inappropriately dilute urine. Lab studies drawn during a period of water deprivation shows low vasopressin level. So what's the diagnosis for her? That's a diabetes insipidus more likely. She has a central diabetes insipidus. It's a clear, folks. Okay. The physician diagnosed. See, they're telling the diagnosis. We are working so hard to get it, and they throw that on the line. All right. So, and then explain that her kidneys are unable to absorb proper amount of water due to defective hormone. That's fine. That's all about diabetes insipidus here. The question is this the one? Which of the following area of the nephron is normally impermeable to water, regardless of serum vasopressin, right? Here, you're going to get two answers. Impermeable to water. People who pick C got confused. They're actually impermeable to sodium. They are permeable to water. Okay. So here, the two answers I expect is D and E. Okay. D and E. You're going to write this concept now, not now when I tell you. In a patient, if I ask you, where do you have the most diluted urine, you're going to answer from now onwards D and E, not just E. It's D and E, folks, okay? I know E I mentioned, it's that the book says that's the most dilute urine, right? Remember, as we ascend, the urine becomes more dilute. Is that clear, folks? So both are diluted urine. D and E is the answer. So how do you pick the answer here? Right? The way to pick the answer, you ask yourself, D and E is the right answer. One is influenced by vasopressin ADH, the other one is not influenced by ADH. So does this patient has ADH? Very low, that means technically no ADH. Answer is D. E is the answer if there is ADH. Okay, now let's write this down. Let's go with notes. So we're going to write it here. Diluted urine is found in two locations, right? In the picture, as it says, D and E. E is your DCT, D is your thick ascending loop. Is everybody clear, folks? They both have diluted urine. The only way to differentiate, I'm going to put vasopressin ADH. ADH influence the DCT. That's all it is. In the absence of ADH, this is the guy who is. They want you to pick D in that question. That's why they have to brought the topic of diabetes insipidus to give you indirectly the patient don't have ADH. Is that clear, folks? If I redo that question and say patient has ADH, then you're going to pick E. Is everybody clear, folks? Okay, I rephrase it. Most diluted urine is found in thick ascending and DCT. Whereas DCT is influenced by ADH, thick ascending is not. Is everybody clear, folks? This is not in the book. This is what we want to write it down to learn. Okay, now let's go back to the question now. If you read the question, they already said diabetes. Now they're asking, the nephron is normally impermeable to water. If I ask you what are the two segments impermeable to water, you're going to say D and E. Is everybody clear, folks? And then which one influenced by vasopressin? E is influenced by vasopressin, D is not. Here, there is no, regardless of serum vasopressin, then D is the answer, folks, okay? That's the answer. Okay.
Can you explain why the ADH affects there? I thought it just affected the collecting ducts.
Yes, that you are right. It only works on the collecting duct. What they are trying to do, what's the function of ADH? Reabsorbing water, isn't it? So what the ADH does, they are preparing to reabsorb all the water. So they communicate with the neighbor who's the DCT to make sure to send more water down so they can reabsorb. It's like a little communication between the neighbor structure. They cannot communicate with D, but they can with E. Is everybody clear, folks? Now, if you look at the explanation, look at this. The ascending limb of loop of Henle is impermeable to water regardless of the serum vasopressin level. That's what we said. Now, if you go for E, water permeability on the early distal convoluted tubule is very low and more electrolytes than the waters are reabsorbed. However, the permeability in this late distal tubule can vary based on the vasopressin. So they kind of influence that. Is that clear, folks? It's a fact, okay? So always ask yourself, if they ask you most diluted urine, you're going to pick two answers, thick ascending and DCT. Then ask yourself, is there ADH or not? If there is ADH, DCT. If there is no ADH, thick ascending. Is that clear, folks? Make sure you write that bullet point there, folks, okay? That's the idea. To recap, all 3 points we learned so far. The first thing we said, in a healthy people, the most concentrated urine is found between the thin descending and thick ascending, that junction, right? That's in a healthy people, okay? Second, we talked about this one, the one we just talked about. Diluted urine found in thick ascending and DCT. If there is ADH, is DCT. Without ADH is thick ascending. Is everybody clear, folks? We are not done yet. We have a few more concepts. All right, easy question. You need to first get me the diagnosis before the answer. If you don't, you will lose the question. Let's read it together. 28-year-old man come to the physician with muscle weakness and headache for the last 2 months. So it's not like 2-3 days, 2 months, okay, chronic. He denies palpitation, tremor, and increased sweating, okay. His blood pressure is high. There you go. When the blood pressure is high, we could think so many conditions, pheochromocytoma, hyperaldosteronism, Cushing's disease. There are so many we studied. We rule out pheochromocytoma because they deny palpitation and stuff. Is that clear, folks? Because they give you episodic symptoms, isn't it? Pheochromocytoma. And I don't see any weight gain so far. And serum potassium is low, okay? And the plasma renin activity is high, and aldosterone is also high. So what's a diagnosis? That's a line here, folks. Actually, all you need is that. The patient's renin is high, aldosterone is high. There's only one disease. Closer, little down, Olivia, almost there. This is a secondary hyperaldosteronism. Secondary hyperaldosteronism means increased aldosterone, increased renin. Primary Cohn syndrome, increased aldosterone, but low renin. Does that make sense, folks? Low renin, okay? Low renin. So this is a secondary hyperaldosteronism. You should be fighting where? No, sorry, not that one. A and C. Secondary hyperaldosteronism means where's the problem? It's not in the adrenal gland. It's not, so rule that out. It's a JG cell tumor or something that overproducing that, isn't it, folks? You see, this was the easiest topic in endocrine, and now it's the most difficult, it seems like, right? So you cannot forget, folks, it's understanding high serum renin and aldosterone. That's it. It's not that you don't know, you guys forgot. Okay, so always remember, if I change this question, let's say I'm changing this to low renin, what would you pick? You're going to go for A. Is that clear, folks? Low renin A, this. If I say this is a pheochromocytoma, then you're going to go for B. Okay, that's pheochromocytoma, folks. All right. If it is pituitary, then what disease is Cushing's? Is that clear, folks? All right. Cushing's disease or anything. Okay. That's that. Everybody clear? All right. You could give two answers if you don't know. And I like two actually. Okay. 34-year-old missionary in Southern Asia is traveling to a remote village and becomes stranded when his bus breaks down. No access to water for 36 hours. They are trying to tell the patient is dehydrated. Is that clear, folks? Okay. Urine, which is urine osmolarity, reaches 1100. That's a concentrated urine. Okay. That's very concentrated. The urine concentration depends primarily on the serum level of vasopressin. We already talked about it. To recap, the two areas urine is always concentrated is one is C, other one is collecting duct. The C is in the healthy people, so that's not an option here. Does that make sense, folks? Because this person is already dehydrated, so the answer has to be collecting duct. But we have two options of collecting duct. Is that clear, folks? All right, so we will leave those two. Which is regulated by, okay, we know that. Which of the following nephron segment responds to vasopressin by increasing absorption of the specific solute that is most important, generating a high medullary concentration gradient, folks, okay? Now they're asking which part of the collecting duct is even more concentrated out of those two. So there's two, cortex and medulla. The collecting duct is running through that, right? If I go to the previous picture to get the picture, now look at this. This is all collecting duct. You see, this is cortex, this is medulla. There are two explanations. They both are concentrated urine, but the urine become more concentrated as you go down because all the water is being extracted. Does that make sense, folks? So the answer is medullary collecting tubule is the most concentrated urine. Plus, number two, here, there's a urea come to play a role. Urea also makes more concentration in medulla, not in cortex. Is everybody clear, folks? You just keep it simple. Medulla is the most concentrated because of the gravity, plus urea play a role, right? Now, if you go back to this question, the answer is medullary segment. Look at that. This is where most of the concentrated urine, folks, you could see here. ADH acts on the medullary segment of the collecting duct to increase urea and water reabsorption, allowing the production of maxillary concentrated urine, folks. Okay, so to recap, during dehydration, your collecting duct will have more concentrated in urine. In collecting duct, medullary will be even more concentrated. Is everybody clear, folks? That's that. Okay. That's another concept. Yeah, let's go. And after this question, you guys probably gonna hate me now. So let's read this question. 54-year-old missionary traveling alone to remote region of the Southern Asia become lost. That's fine. Anytime you hear that, they're trying to tell they're dehydrated. Okay, that's all it is. His urine is, look at that. But the question is, the majority of the total amount of water filtered by this individual glomeruli is reabsorbed where? I know everybody went to collecting duct or medullary duct. The answer is proximal convoluted tubule. Okay, if you remember the book, 65 to 80% of the sodium and water is reabsorbed in the PCT. Remember that I highlighted that. So one concept to learn here, if a question comes, where do you reabsorb water, no matter what, it's PCT, whether you are dehydrated or not, the majority of the water. I agree in collecting duct also you are reabsorbing water, but not to the level of PCT. Is everybody clear, folks? Okay, let's go back and let's confirm. See, that's the answer. It's an extremely difficult question. You could see 38% of the people got it right, and the 30% went to medullary collecting duct. Okay, now let's go back. Let's write this concept. Okay, folks, let's start this page. So first we're going to say concentrated urine. Concentrated urine. Okay. Concentrated urine in healthy people. Healthy is going to be where? The junction, isn't it, folks? The concentrated urine is junction, okay? Junction of thin descending with thick ascending. So whenever you see junction, you should know where it is, folks, okay? And I'm just going to put a letter C. You guys know C is that junction on the bottom. On the other side, concentrated urine dehydrated. Dehydrated. It's going to be collecting duct. Collecting duct, because ADH play a role here, folks. Is everybody clear? In collecting duct, I'm writing there's cortex and medullary. I'm going to put 3 arrows for medullary and 1 arrow for that. So you guys know the most is medullary collecting duct. Is everybody clear, folks? Yes? So with concentration, if you know that, you cannot miss any question. Okay. On the other hand, I'm going to write second one, diluted urine. Diluted urine is found in 2 places. DCT. DCT and thick ascending loop. Thick ascending loop. But DCT is influenced by ADH. Remember that? That's influenced by ADH. I put that. You cannot miss that. Is everybody clear, folks? Okay. So dilated urine is in both DCT and thick ascending, but if there is ADH. So if you notice it, ADH is the one that's playing a role here, folks. Okay. So that's also, because you see here it's also ADH next to each other. Okay. Is everybody clear? Now,
Sorry, I just had one question. You know how we always get like cortex collection ducts and medullary collection ducts? So I'm just trying to figure out how to pick in between 2.
that's
Yeah,
what you
like-
go for medullary. It's always, if they ask you the highest concentrated segment, is always medullary.
They're not gonna ask the cortex one?
No.
Okay.
No. If they could ask you where do you reabsorb more water and give you an option of collecting duct, but within collecting duct, they cannot ask you just a cortex. Okay. Now, third one, this is the one that we are dealing now. Where do you reabsorb most of the water, right? Total water reabsorption, total water reabsorption. There's two locations. PCT, collecting duct. PCT and collecting duct. So we reabsorb water in PCT and collecting duct. And PCT become the answer regardless of that. This will be the highest water reabsorption, highest water, regardless of ADH, So whether dehydrated or not, PCT will reabsorb the majority of the water. Is that clear, folks? That's another concept. See, guys, this is the golden notes. I think this is the most important of today's notes that you took it. That should be understood. Does everybody understand this, folks? If you spend after the class looking at this page for 10 to 15 minutes, it will go. Okay. When you learn first time, it's always hard, but then if you keep looking at it, it becomes easier, folks. Okay. You already know some of them. Let's visit this question now. Now look at this. If you read it, even though this patient is dehydrated, but they're asking the majority of the total amount of water filtered by this individual glomeruli is that. Let's read it. Regardless of the hydration status, the majority of the water reabsorption in the nephron occurs in PCT. Is everybody clear, folks? Okay, so that's that. I'll come to that in a moment. Finish this off. With the information we have now, you could pick one specific answer. Okay, now, when you are careful here, they're doing some research, I get it. The tubular sample is 110. Is this concentrated urine or diluted urine? It's diluted urine. When do you call it concentration in the urine? When it goes more than 350. But did you see the question we had? It's about 1,000, 1,150. They tried. So this is a diluted urine. The minute you see a diluted urine, what are the two segments? Thick ascending or DCT. This, which they didn't even give a letter, or DCT, which is D. Does that make sense, folks? After you know is this or this, what do you ask yourself? Is there ADH present or not? Do they have ADH here? The patient obtain a healthy animal after 12-hour water deprivation. If they're healthy after 12 hours of water deprivation, you should be producing ADH. Does that make sense, folks? If the ADH is present, that makes the answer D is the right answer. Well, even if you don't know that, still D is the answer because they didn't give an option for thick ascending. They should have given an option that would have been more competitive. Okay, so this person has a diluted urine plus ADH. Is everybody clear, folks? So if you know diluted urine plus ADH, it's always DCT. Diluted urine, no ADH, thick ascending. Is that clear, folks? Anybody didn't understand this? All good. So again, this question, folks, okay, if I remove this animal after 12, remove that whole concept, then you should be picking this as an answer. Because if there is no ADH, that's the answer. Is everybody clear, folks? All right. Go back here. Oops, I don't select the answer. D. You could see that's the answer because the presence of ADH. Look at this. The lowest osmolarity distal tubule about 100. They give 110, but still they both are lowest, but this is ADH influence. This is non-ADH influence. Is everybody clear, folks? All right. Very good. Go back. It's an endocrine question. I don't see some answers. Come on, folks, send the answer before I call the names. I have to send something. A to E. So in this chart, what do you see here? I didn't even read the question. I could look at this chart, 1, 2, 3 hours. The osmolarity didn't change a lot. But after 3 to 4 hours, there's a huge jump. Something must have happened between 3 and 4 hours. They said the patient's plasma osmolarity after 3 hours is this. And then they gave vasopressin after 3 hours. So here between 3 and 4, ADH was given. So that means as soon as they gave ADH, it went from 100 to 790, which means all this time the patient didn't have ADH. Okay, that's a central diabetes insipidus. Okay, folks, we did similar to this question in endocrine. If I tell you that, some people picked E. E mean they should concentrate on their own. It shouldn't be a sudden change between 3 and 4 hours like that. Does that make sense, folks? And also, it says clearly the vasopressin was given after 3 hours. Then only you see from 100 to 790. If it is C, B and C, right? One is a nephrogenic, both are nephrogenic, then it shouldn't be 790. It should be in the same range when they are resistant. Is that clear, folks? All right. There's a beautiful chart. I draw this chart for you guys in your endocrine, literally. Take a screenshot of this chart, folks. You can't miss it. Okay. They have normal and they're comparing to all these things. All good? All right, you guys have the ID for all these questions? Okay. Take a break and come back.